Hi, my name is Dr. Tamer Seckin from New York City. I am starting an interview for the ISGE website on a continuum series of our video journal we just launched. And I'm proud to have today Dr. Ornella from Rome. I have just heard a wonderful presentation, her myomectomy experience together with other Italian groups, big number of cases, and I like to share her experience with the viewers. I want to ask first question, how long have you been performing laparoscopic myomectomy?
We start laparoscopic myomectomy in 1991. Of course, in 1991, myoma size was no more than 3 centimeters. Now myoma size can range until 20 centimeters, so we have improved.
And right now, at this point, how many myomectomies do you guys perform a week?
A week, we can say 2 or 3.
2 or 3. And do you scrub together with your partner always, or one of you scrub with a resident?
Sometimes we scrub with the residents. Sometimes we do procedure together if we have multiple myomas and we think it will be a very long procedure. But if we have just 1 or 2 myoma, we scrub with the assistant. When
you start a myomectomy, what is your, at this point of your experience, 4 years, now the learning curve, obviously, I consider myomectomy is the hardest procedure in GYN laparoscopic history. Due to its size, at times we get challenged by, bleeding, second thing, and possibly the fear of other issues with sarcoma or adenomyosis, sometimes getting into cavity. But in your experience, what's your concern when you start a myomectomy?
Okay, usually when I see a patient with multiple myomas, in this case I know that the procedure will be long, and I'm not sure that the patient in 1 year time will not have again myomas. So sometimes I have a feeling, a personal feeling of an unuseful operation. That is something really that upset me. Say, okay, she has now 8 myomas, probably in 2 years' time they will have 5 more. That is something, the problem is nothing to do with the procedure I'm doing, but is a concern for the patient.
So in other words, you question yourself, even though you believe you do the right thing at that time for the patient, you remove whatever visible and feelable or picked up by sonogram, you do your best, and you know there will be 2 issues after that. One is there are small myomas you will still miss. The second is there will be new fibroids coming. I don't think you should be feeling bad about it, because if the patient knows that you're doing your best to either prevent a hysterectomy or to help her to get pregnant. So you should. My personal fear in a myomectomy is really it becomes an issue of how I will remove the specimen. I'm not a very proponent of morcellators from above, and I do feel that my copotomic removals I have found experience and grow confident in it. And the other thing is obviously bleeding, and I am also very afraid of pressing you to something personal because of my experience. Apparently, as I discussed with you before, your experience with pitressin has never been any adverse effects, or what you heard from your friends in that big series that you have, any pitressin accidents?
No, we didn't have any problem with pitressin. We use, it's very diluted, because we use 1 in 500, so in a way it's very, very, very diluted.
How long does it last to keep the non-bleeding stage?
More or less 20 minutes.
And then every 20 minutes you have to infiltrate again?
Yes, but usually in 20 minutes you will be able to remove the myoma and you start the suturing.
I see. I want to, for the sake of our viewers from all around the globe, we believe at ISGE we want to empower the individual surgeon from wherever they are. Some are there of them new members, young residents just finishing their program, going on to practice. They will be starting these procedures. What do you advise to new laparoscopists who are starting this What can they do to cut their learning time, and what are the initial highlights?
I suppose myomectomy, you need to be able to suture. If you can remove a uterus and not be able to suture, you can remove an ovarian cyst and not be able to suture it. With myomectomy, you must be able to suture. So, in my opinion, before starting to do surgery of a live patient, you will need to spend a lot of time on the pelvic trainer. In my opinion, you cannot use a patient as a pelvic trainer.
So suturing is a must?
Suturing is a must. And the second thing, you can start with smaller things and go on as soon as you will get more confidence about the procedure.
And the other thing, probably you would like to say bleeding control, being expert on bleeding control.
Okay. But we don't use so much electrosurgery during myomectomy, because you inject vasopressin, you remove the myoma, and usually you start to apply suture. So in most of the cases, you don't have so much bleeding. You must be careful. For instance, in some very easy pedunculated myoma, some of the residents make the same mistake. They inject vasopressin next to the big vessel. In this case, you can have a massive bleeding while you are injecting vasopressin in pedunculated, easy myoma. So for, I don't know, pedunculated myoma could be easier, at least at the beginning, to use an endoloop and tie the endoloop.
And my final two questions. The first is, for patients who are infertile and failed IVF, and they come to you for myomectomy, what are the considerations on these patients that are different from hysterectomy alternative myomectomy?
If the patient comes from, if she has a myoma.
She has failed for IVF, or they have referred you for, before even they attempted IVF, they want their fibroids to be removed. What, in practical, you make sure if the cavity is regular, the general feeling at times, many times, that the other fibroids may not need to be removed.
Usually no, not all the myoma needs to be removed for a good fertility outcome. So usually if the patients come to me, the cavity is normal, the myoma is not so big. If she has a big myoma, probably it could be better to remove it because you can have problem in the pregnancy. But you know, I have a strange story. Once I saw a patient, she came to me and she was already pregnant. It was the first time I visited her, and when I visited, I say, "Oh, mom, she had something like 10 myomas. The size of this myoma was 5, 4, 8, 9, and the baby inside." I was really worried for this pregnancy, but the pregnancies went on. And I used to call this baby sandwich, because in all the ultrasound it was saying like this, with all the myoma. And at the end she had a cesarean section after an uneventful pregnancy. Because she wanted another pregnancy, I removed the myomas before the second pregnancy. During the second pregnancy, she had more problems than during the first. She had preterm risk most all over the last months. So,
there's always questions whether when you want to help, it may not be the same.
But anyway, if the myoma is encroaching the cavity, I think it's good to remove it.
And final question. What are the instrumentation that you personally use for myomectomy?
Very basic instrumentation, because in Italy we don't use disposable, so we have reusable trocar, we have bipolar forceps, we have a tenaculum to pull the myoma, of course very good needle holders, and moisturization system.
Thank you.
Also the ultracision is reusable.
Thank you. Ornella Sizzi from Rome.
Okay, thank you.